with sleep. So why is sleep important? Well, sleep plays a really vital role in our good health and well-being throughout our lifespan. And getting enough quality sleep at the right times can really help protect our mental health, our physical health, our safety, and our overall quality of life. The way you feel when you're awake really depends a lot on what happens when you're sleeping. During sleep, our body is working to support healthy brain functioning, maintain our physical health. There's a lot of really important functions of sleep that really are essential to maintaining our health and well-being. And when we're children and teenagers, sleep really also helps support growth and development. So in terms of mental health, our brains are forming pathways to help us learn and remember information while we're sleeping. If you're sleep deficient, you're going to have difficulty making decisions, solving problems, controlling emotions, coping in general. And sleep deprivation has been linked to suicidal thoughts, suicidal behaviors, depression, and risk-taking. I know that when I don't get a good night's sleep, you can just expect that I will cry at the drop of a hat. Small problems feel like big problems. And my ability to maintain my cool and not lose my composure and snap at my family, right? All of these things get really impacted if we've had a couple of bad nights of sleep. So sleep and mental health, that connection is super strong. In terms of physical health, repair, a lot is happening while we're resting. So while we're sleeping, we have repairing and healing of heart and blood vessels. Sleep deficiencies have been linked to increased risk of heart disease, kidney disease, high blood pressure, diabetes, stroke, obesity. I don't know how many of you have had this experience, but when you are sleep deprived, my guess is that you actually feel hungrier throughout the day. And the reason for that is because while we're sleeping, our hormones are getting regulated. So we have these hormones called ghrelin and leptin, which regulates our feelings of fullness and hunger throughout the day. And when you're not sleeping well, those hormones are dysregulated. So you get the hungry munchies if you haven't had a full night's sleep. In terms of safety, our reaction time is much slower and we make more mistakes and we're less productive when we're sleep deprived. You can just look at some of the data on drowsy drivers, which is a factor in about 100,000 car accidents each year, which results in 1,500 deaths. So there's a reason why we don't let people operate airplanes or heavy machinery when they're really sleep deprived. It's because it's just not safe. And so when you take all these things together, sleep has an incredibly important impact on our quality of life. Without our regulated sleep, our mental health, physical health, and safety really take a dip. Oh, let's see if I can advance. Okay, I want to give you a very basic overview of the sleep cycle. So there are two basic types of sleep. One is rapid eye movement, or REM, REM sleep, and then there's non-REM sleep. So you cycle through all stages of non-REM and REM sleep several times during a typical night, with increasingly longer and deeper REM periods occurring towards morning. So in stage 1 sleep, this is a non-REM sleep. This is the changeover from wakefulness to sleep. And during this short period, which only lasts several minutes, it's relatively light sleep. Your heartbeat and your breathing and your eye movements begin to slow, your muscles relax with occasional twitches, and your brain waves begin to slow from their daytime wakefulness patterns to a more restful pattern. In stage 2, non-REM sleep is a period of light sleep before you enter that deeper sleep. And in this stage, your heartbeat and breathing slow even more, your muscles relax even further, your body temperature drops and your eye movements just stop. Your brainwave activity slows, but it's marked by these brief bursts of electrical activity. And you spend more of your repeated sleep cycles in stage 2 sleep than in any other stages of sleep. And stage 3 non-REM sleep is the period of deep sleep that you really need to feel that refreshed feeling in the morning. So it occurs in longer periods during the first half of the night. And in this cycle, or in this stage of the cycle, your heartbeat and breathing slow to their lowest levels during sleep. Your muscles are completely relaxed, and it may actually be quite difficult to wake you up. And brain waves become even slower. And then there's REM sleep. So this first occurs about 90 minutes after falling asleep. Your eyes move rapidly from side to side behind your closed eyelids, and there's a mixed frequency of brainwave activities becoming kind of almost like what you would see in a wakefulness pattern. So this is the stage in which dreaming usually occurs, and your brain activity mimics that wakefulness pattern. Your breathing becomes faster and more irregular. Your heart rate and blood pressure increase to some near waking levels, and most of your dreaming occurs in REM sleep, although some of this can also occur in non-REM sleep. What's really interesting in REM sleep too is your arm and leg muscles become temporarily paralyzed, which actually serves to prevent you from acting out your dreams. So I don't know if any of you have dogs. My last dog, who passed away in April, she was a dream runner, right? But her legs weren't fully running. They were just sort of twitching, right? Little paw twitches. She was in REM sleep and she was dreaming about chasing rabbits or something. We do this too, but our bodies are more paralyzed, which is important so that we're not acting out our dreams and causing ourselves or others damage. All right, so sleep and aging. Our needs for sleep change throughout our life course. So, I think I first gave this speech or this talk when I had a really little baby. So I had she was 5 or 6 months old at the time, and she was incredible. She would sleep 12 hours overnight and then take 2 2-hour naps throughout the day. So she required about 16 hours of sleep in a 24-hour period. As kids get older, they drop a nap. They sometimes drop both their naps. And our needs for sleep change. Now my kids are 5 and 7, and they both get by with around 11 or 12 hours overnight without naps. Still incredible sleepers, thank goodness. But they're not going to sleep 12 hours forever, right? If anyone on the call is an adult who sleeps 12 hours, I have questions. Most adults cannot sleep 12 hours of a 24-hour cycle unless you're like sick or in recovery from an illness, right? Most adults really only need about 7 to 9 hours in a 24-hour cycle, but this continues to change throughout adulthood and later life. So let's talk about normal expected changes related to sleep in later life. So as we age, we actually start to need less total sleep. And this is specifically at night. And part of this is due to a delayed onset of sleep. So it takes older adults a longer time to fall asleep. That is normal, that is expected. And part of this is there's really good reasons behind it. So one of them is this idea of an advanced circadian phase. So advanced circadian phase essentially means early to bed, early to rise. So my grandfather, when we would visit him in Florida, he would always wake me up at like 4:30 in the morning when he was like up and making fresh squeezed orange juice, which was like a lovely way to wake up with fresh squeezed orange juice, but not at 4:30 in the morning. But this is a very normal pattern for older adults. They go to bed early, they wake up early. This is due to how their bodies are responding to the environmental cues for sleep and wakefulness. Older adults are also much easier to wake. So I don't know if you've ever tried to wake up a teenager, you can't do it, right? They're just dead to the world, completely unable to wake them up at all. But older adults wake up very easily. They'll wake up from a small sound, from a sudden gust of air, right? Like there's just this reduced threshold for arousal from sleep, which can lead to older adults having more fragmented sleep and multiple waking arousals or wake ups throughout the night. And also we see a change in sleep quality. So older adults are actually getting less REM sleep and less slow wave sleep. Also, because they're easier to arouse from sleep, they're waking up throughout the night more often. And you'll often, when you're working with older adults, hear that, I get up to go to the bathroom 2, 3, 4, 5 times throughout the night. And you might think, oh, this is because you're having like urinary problems. Well, that might be, but it might also be that they're just generally waking up more. And once they're awake, they're like, I might as well go to the bathroom. Or it might be that their need to go to the bathroom is causing them to wake up because their threshold for arousal from sleep is much lower. So these are all kind of normal and expected changes in later life. And because these older adults are getting more fragmented sleep with multiple arousals as they wake up, we expect to see some daytime napping to make up for the poorer quality and reduced hours of sleep at night. Okay, so that's normal and expected changes. Now I want to go over a list of common sleep disorders that are especially common in later life, and we'll go through each of these abnormal sleep changes together. So we'll talk about insomnia, REM sleep behavior disorder, narcolepsy, periodic leg movements, restless leg syndrome, and sleep apnea. Okay, insomnia. So I think we're all familiar with this term. It gets thrown around a lot, but to be clinically, but we'll go through the clinical threshold for the difference between having a bad night's sleep and having insomnia, like big I insomnia. Um, so there's primary and secondary insomnia. Primary means there's no other problem. The problem is insomnia. Everything else is fine, but you just can't sleep and you can't go to sleep, you can't stay asleep, or you wake up really early, and there's no real reason for it. With secondary insomnia, that usually means that that the sleeplessness is resultant of something else. For example, terrible back pain is causing me to wake up or have trouble falling asleep, or my breathing problems make it so that I cannot fall asleep and stay asleep easily. And that would be secondary insomnia. With older adults, it's also important to note that a lot of medications can exacerbate insomnia. So anything that is a stimulant, for example, almost all steroids can make insomnia much worse. A lot of older adults are on diuretics, which can make frequent urination a problem that interferes with sleep. So there's always, when people complain, especially older adults who tend to have lots of multiple medications, when they're complaining of insomnia, it's important to look through their medication list and see if there's any medication that might be interfering with their sleep. About 50% of adults over the age of 65 report some challenges with their sleep, and this is more common in men than in women than in men. Okay, let's continue to talk about those common secondary causes of sleep. So the first is age-related changes. So in age-related changes, we're talking about things like frequent urination or musculoskeletal disorders. A lot of times these are the primary problems, and then the secondary result is difficulty sleeping. A lot of mental health problems and cognitive disorders can also cause difficulty with insomnia. So for example, with depression and anxiety, sleeplessness or difficulty falling or staying asleep is a secondary symptom of depression and anxiety. And with dementia, especially Alzheimer's disease, there's a lot of disruption in circadian rhythms. So circadian rhythms, I think people are probably familiar, but in case you're not, it's just our natural pattern with the built environment. So, if we're a diurnal creature, meaning we sleep at night, we're awake during the day. The reasons for that is because of actually what the light does to our brains. It triggers certain wakefulness hormones and certain sleepiness hormones when the light goes away. It's why there's been this big push to get us off of screens at night, or if you're going to use screens, to make sure the blue light filter is on, because we don't want to confuse our brains into thinking, oh, it's like 9 a.m., start producing the wakefulness hormones when it's 10 p.m. and you should be getting ready for bed. In Alzheimer's disease, and also in Parkinson's and other dementias, our natural ability to regulate our sleep and wake cycles gets disrupted. Caregiving can be a common secondary cause or primary cause for secondary insomnia. So caregiver stress can keep people up at night. Caregivers of patients with Alzheimer's disease report more insomnia than other populations, primarily due to Alzheimer's disease patients having those circadian shifts, right? You've heard of sundowning in Alzheimer's disease. That's when patients living with Alzheimer's disease get more agitated and more disrupted in the evening than during the day. So a lot of times with folks with Alzheimer's disease, they end up kind of switching. They sleep all day and then they're awake and agitated at night, and that can be extremely challenging for caregivers. And then I say, as I drink my my Pee Wee Herman coffee, which is decaf, I should say, but caffeine is a huge culprit for insomnia. So whenever I work with someone who has insomnia, the very first question I ask is, how much coffee do you drink and until what time? And that's because most people are not familiar with the half-life of caffeine. So quick chemistry lesson, the half-life of a chemical compound, which is, what caffeine is, half-life means the amount of time for half of it to leave your system. So with caffeine, the half-life is actually around 5 or 6 hours, which means that if I have, what time is it now? Let's call it 10 a.m. If I have a cup of coffee at 10 a.m., my decaf, but let's pretend it's real coffee. If I have a cup of coffee at 10 a.m., it's like I'm having half a cup of coffee at 10, 11, 12, 1, 2, 3, 4, at 4 p.m. Okay? So if you're drinking like 6 cups of coffee, 4 cups of coffee throughout your morning, just half it for 6 hours later. So whenever someone's like, I've got to have my 3 p.m. coffee, I'm like, cool, right? That's fine. But that's like having half a cup of coffee at 9 p.m. So we really want to think about caffeine intake because it's actually one of the easiest things to fix with insomnia. Because it builds up, right? If you have 2 cups of coffee at 9 p.m., it's like having, or at 3 p.m., it's like having 1 cup at 9 p.m. It's not going to help you fall asleep at 10 p.m., right? And certain medications also can be really tricky for insomnia. Any stimulant like ADHD medications or steroids can make it really hard to fall asleep. Okay, so here's a list of substances that can make it tricky to fall asleep, right? So a lot of people think that alcohol helps them fall asleep, and it can help you fall asleep for some, but it's going to wake you up in the middle of the night. So it actually leads to more fragmented sleep. So one of the pieces of advice I give to people who are like, but I gotta have my glass of wine, I'm like, okay, but do it as early as possible, right? Have a happy hour drink glass of wine, not a nightcap. Nightcaps are not good. And then here's a list of other medications that we often see older adults on that can really impact the ability to fall asleep or stay asleep. Okay, so let's talk about clinical insomnia. So in order for someone to meet like the DSM-5 criteria or the ICD-10 criteria for insomnia, we need to see a difficulty falling or staying asleep, fatigue or daytime sleepiness, impaired memory or concentration, impaired social performance, lower energy, mood disturbances, concerns, or dissatisfaction with sleep, and it cannot be due to anything else. And we want to see this, well, we don't want to, but we have to see these symptoms at least 3 times a week for at least 3 weeks. You don't need all of these symptoms, but you definitely need the first symptom, difficulty falling or staying asleep. That's like you have to have that to get into the rest. And then I think it's 3 or 4 of the other symptoms as well. So it's that, but let's pay a little bit more attention, at least 3 times a week for at least 3 months. So I point this out because all of us will have a bad night's sleep from time to time, right? And all of us might have a bad week of sleep because something really intense is going on, or just, something's happening that's really making it a problem. But in order for us to call it clinical insomnia, we need to see this pattern sustained at least 3 times a week for at least 3 months. And that's when we would consider it like really clinically significant insomnia. Now, that doesn't mean that we can't help our patients or our friends or our family members who are struggling with sleep less than 3 times a week for less than 3 months, I still think it's really important to think about, good sleep hygiene generally. But I do think that this is an important threshold to be aware of. Okay, insomnia treatment. So behavioral treatments, non-pharmacological behavioral treatments are considered the gold standard in sleep. So when we say this, we mean things like improving our sleep hygiene, cognitive behavioral therapy for insomnia, and stimulus control are really the gold standard for sleep. And I will say they're really, really, really effective. We can solve a lot of people's sleep problems by understanding what their patterns are. And I'll get into the sleep hygiene stuff at the end of the talk, but I love when people come to me in my practice for sleep challenges, because I would say in 95% of my cases, they have some behaviors that are unintentionally making it more difficult for them to sleep. And once we modify those behaviors, their sleep improves. When it's beyond just like sleep hygiene behaviors, we launch into cognitive behavioral therapy for insomnia, which helps challenge some of the unhelpful thinking patterns around sleep and insomnia. So like sometimes we have people who think that they should be sleeping 10 hours a day. And that's not really real, right? Most people are totally fine with 7 or 8. So we work on sleep expectations and thoughts and thinking patterns around sleep. Some people end up feeling a lot of dread before they go to sleep. So we work on that anxiety around sleep. And then stimulus control is things like only using your bed for sleep, so that we start to associate bed for sleep and not for, reading or working or stressing or talking on the phone or any of the other things that sometimes people do in bed. And then medication is really considered the last option. Especially for older adults, because most of the medications that are prescribed for sleep are really counterindicated for older adults due to an increased risk of falls and delirium. So we really want to focus on these sleep hygiene, CBTI, stimulus control treatments before we launch into a medication-based treatment. Okay, so let's talk about some of the other disorders. So REM sleep behavior disorder. So this is categorized by people who act out their dreams. And this is mostly men who do this, and it's mostly older men. And it's really can only be diagnosed by taking a history and then doing a sleep study. The reason this is happening is that during normal muscle tone, or most people, are in that paralysis during REM sleep, but for people with REM sleep behavior disorder, there's a loss of normal muscle atonia, or that sleep paralysis, meaning they're acting out their dreams. It's about 90% men, mostly over the age of 60. And what's really interesting is that this sleep disorder in particular is extremely associated with neurodegenerative conditions like Parkinson's, MS, and AD. So much so that people are starting to wonder if this is maybe a prodromal phase, like an early phase of these conditions. Usually we find out about this because they've hurt their bedmate, they've hurt their partner. They've thwacked them while they were sleeping or things like that. I had one patient whose wife came in with a black eye and he said, I didn't do it. She's like, you did it. You were just asleep. So, if anyone comes to you saying anything about, my partner acts out his dreams or my partner hit me in their sleep, I would, query a little bit more to find out if there's REM sleep behavior disorder happening. So narcolepsy, this is categorized by sleep attacks. So excessive daytime sleepiness and then transient loss of muscle tone. So people literally just fall asleep on the spot. It's really rare to have a new onset or a first diagnosis in later life. Usually this is a lifelong disorder that's diagnosed in the teenage years. Again, it really needs to be properly diagnosed with a sleep study. But this disorder can cause lifelong problems and really does require management and medication. So the management is lifestyle changes, and then the medication is specific medication to help people stay awake during the day and to help them go to sleep at night. Periodic leg movement disorder. Again, another disorder that needs to be diagnosed with a sleep study. So this is a unique motor disorder that occurs really only during sleep, and the prevalence of this increases with age, with up to 45% of older adults having this. They might be asymptomatic, but if a patient is complaining of insomnia, it may be worthwhile to investigate this a little bit more. So periodic leg movement disorders, like the legs will like kind of jump up and down while they're in those early sleep phases, and then they wake up and they can't fall asleep. But again, you can't really diagnose this without a sleep study. Restless leg syndrome. So this is unique from periodic leg movement. So with restless leg syndrome, people report feeling these like tingly, crampy, painful, like creepy, crawly feelings in their legs. And they really feel like they have to move or massage their legs, but they're intentionally moving their legs. Whereas with periodic leg movements, the legs are just involuntarily having twitches and spasms. This can cause a lot of difficulty falling asleep, and we see it mostly in women, and it's around 10 to 35% of the older adult population. There is a genetic component, so about 50% of people who have restless leg syndrome have a family history of having restless leg syndrome. We often see people with restless leg syndromes also having iron deficiency, renal failure, neurologic lesions, peripheral neuropathy, and rheumatoid arthritis. And the treatment for this is actually L-DOPA or other dopamine agonists, which can decrease the symptoms. Which, because the L-DOPA tends to work, that people sort of think that maybe this is an abnormal dopaminergic neural transmission that's causing these restless leg syndrome symptoms. But really the important thing is we can treat it. So if people are saying my legs feel tingly, crampy, painful, whatever, at night, I would investigate further for restless leg syndrome. And the way you do that is you can screen for it. It's actually quite easy. So this is just a clinical interview, no sleep study. Do you experience the urge to move your legs? Does the urge to move or the uncomfortable, unpleasant feelings start or worsen when you're resting or relaxing? Is it relieved by movement? And does it worsen in the evening or occur only in the evening? So this 4-item screener will give you a pretty good picture of whether or not you got restless legs. All right, sleep apnea. So this is categorized by an upper air obstruction, which leads to a poor quality of sleep and often the reduced or complete absence of REM sleep. So with sleep apnea, you have terribly, terribly interrupted sleep, but they may not know it because they're not going to necessarily wake all the way up. They only end up having, they essentially cycle from phase 1 to phase 2 to phase 3. Maybe they'll start to enter REM, but then during REM, they get woken up and they go back to phase 2 or phase 1. So they're not necessarily waking all the way up, but that reduced or absence of REM sleep has some really bad downstream effects. And so maybe they're only aware that they snore. They may not be aware that they're having these apneic episodes where they're actually not breathing. So if you're a partner of someone with sleep apnea, the snoring will sound a little different, right? It won't just be I'm going to try to do my impression of apnea snoring, but this is going to probably be terrible. I'm so glad this will be recorded for everyone and to watch on YouTube. But with apnea or with a normal snore, it's sort of the kind of constant noise. But with apnea, there's going to be a catch. So it's kind of like right? So there's like this, I'm sure this is lovely for y'all to listen to. There's this moment where it catches and you can almost hear them not breathing, right? So sometimes the partner helps with the diagnosis, but again, this really needs a sleep study for conclusive diagnoses. Often it's men who suffer from sleep apnea, and people who are overweight can have a higher risk for sleep apnea because of the excess weight on their neck kind of shutting down those airwaves when they lie on their back or when they lie down. But it's not just overweight men who have sleep apnea. I worked with patients who are very small framed women who also had apnea. It has to do more with sort of, and children can get it too. A lot of times when kids have it, they end up removing their tonsils, and that really helps open up the airway. It can be very structurally based, not just like secondary to other conditions. But the reason why it's so important to treat sleep apnea is because if you don't treat it, people have a higher risk of stroke, heart attack, depression, cognitive impairment, etc. I've seen patients who come in with memory problems, and you'll do like a cognitive screen on them, and you start to think, oh, you have mild cognitive impairment. Like this is, maybe an early phase dementia. But then you realize they have sleep apnea, you treat the sleep apnea, and their cognition comes back online and they no longer screen positive for mild cognitive impairment. So treating sleep apnea is really life-changing for people once it's been properly diagnosed. Here are some additional symptoms of sleep apnea. Irritability, daytime sleepiness, fatigue, headache, memory concentration difficulties, depression. And again, you should see a lot of these remit when you treat it properly. So how do you treat sleep apnea? There's really one treatment, it's CPAP. Some people are candidates for these orthodontic things. Like if you have very mild sleep apnea, they might be able to fit you with an orthodontic like mouth guard that helps position your airways more properly so they stay open. But really, most people are going to need a CPAP machine. And some people have no problem with CPAP, no problem at all. They wear it, it's fine. But other people report hating their CPAP machine. And if they really hate it, there are a lot of things we can do. So the first thing, the number one problem is that their mask is wrong. CPAP masks are constantly changing. So it might be that you just got whatever mask came with the machine, but that's not the right size mask or the right type of mask for your unique facial structure. And so the first thing I would recommend if a patient says they hate their CPAP is send them for a mask fitting, where they can actually try on like 15 different masks and get it exactly sized and like tailored to their unique facial structure. But then if they're like, okay, the mask is perfect, but I can't stand it, I feel claustrophobic or whatever, which happens, then we have a type of behavioral therapy called CPAP desensitization therapy. So you can send them to someone who does this, or you can help coach them through it yourself. The basic idea is you have someone slowly get comfortable with the CPAP machine before it's time to go to sleep. So, while you're watching TV this afternoon, wear your CPAP for 5 minutes. Oh, you can do it for 5 minutes. Great. Now do it for 10 minutes. And you build them up until they're kind of able to wear their CPAP while doing relaxing, watching TV, reading a book, whatever. And then hopefully that helps them get more used to it so that they can do it at night. All right, so now I want to briefly run through sleep hygiene tips and leave a lot of time for questions and comments, because I cannot see the chat at the moment, but I see that there's been a lot of activity in it, and I really want to make sure we have time to chat. It's my favorite part about these talks. So sleep hygiene tips. So the first one I want to say that's not listed here, there's a basic principle in sleep that people sort of don't realize, but it's important. In a 24-hour cycle, if you want to sleep for about 8 hours, you have to be awake for 16 hours. And you pretty much have to be awake for 16 hours in a row. Some people can get away with a nap, but most people can't. And the reason I say this is because sleep is a drive, just like hunger and thirst is a drive. So if you had a giant meal at noon, would you be able to eat another meal at 3 p.m.? Probably not, right? Because your hunger drive has not built up enough. And so with sleep, you have to be awake for 16 hours to expect to sleep for 8. So if you go to bed at midnight and you wake up at 8 a.m., I would not expect you to be sleepy again until it's midnight again. And let's say, it's the weekend, you go to bed at midnight and you're like, oh, I'm going to stay in bed until 9 a.m. today. Okay, great. But you might not be ready for bed at midnight the next day because you haven't been awake for 16 hours. So usually your bedtime and your wake time and your bedtime should really be as close to the same every single day as possible, because people run into trouble when they're like, well, I went to bed at 2 a.m., so I'm going to sleep in until 10 a.m. And then tonight I'm going to try to go to bed early because I went to bed so late last night. Well, you're not going to go to bed early if you were in bed until 10 a.m. Your sleep drive just hasn't built up enough. Or, a lot of times people are like, I slept terribly last night, so I'm going to get in bed at 8 a.m. or 8 p.m. tonight because I just had a horrible night's sleep last night. Well, I believe that you had a horrible night's sleep, but if you slept until 7 or 8 a.m., even if it was fragmented, if you were asleep from the hours of like 6 a.m. till 8 a.m., you're not going to be ready for sleep 12 hours later. We have to build up that sleep drive. So I tell people, don't go to bed unless you're actually sleepy. If you're not asleep after 20 minutes in bed, get out of bed. We do not want your bed to be associated with anxiety or stress or wakefulness. So if you haven't fallen asleep after 20 minutes, get out of bed, go somewhere cozy, read a book for a little bit, and then get back into bed when you feel drowsy. I really like people to have these bedtime rituals to help them get ready and relax before bed. It doesn't have to be long, but something like, brush your teeth, put some lotion on, maybe do a little bit of stretching, and then get into bed. Wake up at the same time, go to bed at the same time, super important. That regular schedule is really important. Using the bed for sleep only. So I know a lot of people like to read or watch TV in bed, and that might work fine for you, but if it's not, move your wakeful activities to a different space. No caffeine after lunch, no alcohol within 6 hours of bed, no nicotine before bed. So remember, caffeine's half-life is 6 hours. So anything that you have after noon is still going to be in your system when it's time to go to bed. Alcohol really will cause fragmented sleep at night. Might help you fall asleep, but it's not going to help you stay asleep, and it'll make you really thirsty too. And nicotine is a stimulant. So having that before bed, it's going to rev you up. We don't like people to go to bed hungry, but we also don't like you to go to bed having eaten a big meal right before bed, because your body has to digest that meal, and the process of digesting can help keep you awake. We usually don't like people to exercise within 6 hours of bed, because that elevated heart rate can be hard to come down from. We do like people exercising first thing in the morning, though, especially if it's outside, because then you're getting that bright light right away, and it's helping your brain produce the wakefulness hormones. You're awake now. Sleeping pills are a short-term strategy that can really mess with you long-term. A lot of people report not being able to go to sleep because they're worrying. So a lot of the times we say, okay, worry, for a lot of people, it's hard to control that worry, but I like it when people move their worry earlier in the day. We call it constructive worry time. So instead of getting in bed at 10 p.m. and then thinking, oh, here are all the things that have been bothering me all day, because it's the first time it's quiet, it's the first time my brain has time to think. Just, at 5 p.m., sit down for 20 minutes with a pen and paper and say, what are the things that I might worry about later tonight? And write them down. And then, when it's 10 p.m., you can say, I already did that. I don't need to do that again. And then napping. So napping can be really alluring, but it's going to mess up your sleep drive. So usually if someone's like, but I got to have my nap, well, that's fine. Some people can have naps and be fine. But if it's interrupting your nighttime sleep, I would try to skip it. And if you absolutely can't skip it, make sure it's before 2 p.m. and try to keep it under half an hour. All right, so that's my email address. I would love to hear from you if you have any questions. I would especially love to hear from you if you're at all interested in the Population Aging Masters in Public Health or Certificate Program, which you can do entirely online, remote, asynchronous. You don't have to leave the workforce. And that is all I've got. So I'm going to stop my share and open up the chat and see what we've got.
Well, thank you so much, Dr. Kozlov. That was very informative, especially for me, someone who enjoys sleeping and napping. And I'm pretty sure it was definitely informative to the audience. You mentioned, you shared your email, so that was a question that a lot of folks asked about if you were going to share your information. Before we start with questions, can you also share your slides because they are interested in a copy of the slides? So I could always send that out after the webinar.
Yeah, I'm okay with that.
Okay, thank you so much. So we have some questions here. I think you did mention napping. Someone said, can you speak on midday naps? Is there a scientific duration? Example, 15 minutes that is actually helpful.
Yeah, so it kind of depends on what the goal of the nap is. Um, so if the goal of the nap is to make up for sleep you didn't get last night, you're going to want like a 90-minute or 2-hour nap so that you can get a REM cycle in, but that's going to mess up your sleep drive later on. If the goal of the nap is to just like quickly feel refreshed, about 20 minutes. But I, again, would not do it after 2 p.m.
Great, thank you for that. What would you say is the role of warm milk as a sleep aid?
Oh man, I used to know the answer to this. There is a chemical in warm milk that can help aid with sleep. But what I will say is, and maybe this is like the having had 2 kids part of me, like I don't like to drink a lot of liquid before bed because that's going to make it more likely that you're going to wake up to have to use the bathroom.
Do you become dependent on CPAP machines?
So that's an interesting use of the word dependent. So what I would say is that if you have sleep apnea that is like very structural, it's not that you're dependent, it's that it's what you need, right? Like it's if a lot of people who have sleep apnea need to use their CPAP in order to have their airways stay open while they're sleeping. Some people can fix their sleep apnea by losing weight, by wearing orthodontic appliances, but a lot of people will be on CPAP for the rest of their lives because it's what their body needs. Sort of the same way that like I need glasses to see the screen. I could take them off, but now I can't really read what's happening that well. Um, you could not use your CPAP, but you're not going to get enough oxygen while you're sleeping. You're not going to feel good. So that's how I would consider that.
Great, thank you. What about ringing in the ear? Some nights are loud and difficult to sleep.
Uh, yeah, tinnitus is a real frustrating problem for people who have that, who have it. Tinnitus can be really tricky. Um, and there's a lot of different ways to think about and to handle tinnitus. Different things work for different people. Some people really like white noise to help drown out the tinnitus. Other people say it aggravates it. Some people like earplugs because like the pressure can feel good with tinnitus. So, um, a lot of times with tinnitus, it's about like coping with it and finding what works for you.
Great. This question is, how does melatonin work? That's one, but I also wanted to add, what about people who uses NyQuil to go to sleep?
Oh gosh.
So two
Okay.
different questions,
Yeah,
obviously.
yeah. So melatonin is a naturally occurring hormone in your body. And melatonin automatically starts getting produced by your brain or like triggers your endocrine system. Your brain triggers your endocrine system to produce melatonin. Um, it automatically starts to happen in the evening hours. I know that there's people are obsessed right now with supplemental melatonin. Frankly, most people really don't need it. There are people who are melatonin deficient, um, and then they need supplemental exogenous or like melatonin that you take into your body. But most people produce plenty of melatonin and do not need additional melatonin. It can make people feel sleepy, so people like it for a sleep aid. All melatonin supplements are not created equal, so do your research because the whole world of supplements is completely unregulated, right? Completely unregulated. So I always get really anxious when people talk about supplements because I'm like, there's no data on this one versus that one. It gets really tricky. Most people do not need supplemental melatonin. I do think it can be really helpful though for like time zone shifts. So, right, if our body naturally regulates based off of when we see sun, when we have darkness, etc., that's going to get wonky if we're jumping time zones. So taking melatonin can help cue your brain to be like, oh, like you're trying to tell me to go to sleep, but I think it's 7 p.m., but over where I am, it's now 10 p.m., right? So it can help with that. In terms of NyQuil, and any other like cold or over-the-counter medicine, what are the other ones? Unisom, NyQuil, Benadryl. Oh, I don't love it. I don't love it. It's a Band-Aid, you know? It's not something that you can take long term. Do people do it for a night or two here and there? Of course they do, and maybe that's okay. But our bodies really, really like homeostasis, right? Our bodies really, really want to have everything be balanced. And probably if you just gave it a few days, your body would naturally get itself balanced again. And I tend to think that most of the things we do to compensate for sleeplessness guarantee future sleeplessness. So, we compensate by drinking more coffee when we don't sleep well. Well, that's going to have more caffeine in your system when you try to go to bed the next night. We compensate by taking naps. Well, that's going to decrease your sleep drive. We compensate by sleeping in or going to bed early. Well, that's going to mess up your sleep time and your wake time for the next day. So, in general, our bodies really would just like it if we could go to bed and wake up at the same time every day. And even if we don't sleep well, tell ourselves, it's okay to not sleep well for a night or two. It'll get back to normal naturally.
Thank you for that. What about looking at your phone before going to sleep? Is this a good idea?
I mean, this is so hard, right? Like, technically, no. But in what world are we all going to all of a sudden put our phones in another room and never look at it? You know, it depends on what you're looking at your phone for. If you're looking at your work and you're getting stressed out by all the things you have to do tomorrow, no, terrible idea. Don't do that, right? If you're reading the news and you're getting really depressed about all of the horrible things that are happening all over the world, like definitely don't do that before bed. If you're using a meditation app, that sounds good, right? That might be helpful. It kind of depends on what you're doing. So, and make sure you have a blue light filter on your phone. Almost every phone now has like nighttime mode on it. Just make sure that's checked. And at least from the like technical aspects of like the light affecting your eyes and all of that should be mitigated.
Okay, great. Do you have some go-to tips on falling asleep? Things like counting backwards, etc.
Totally. So I have two that I recommend all the time. My favorite one is counting breaths, but I don't count indefinitely up to like 150, right? Because that's stressful. If I've counted my breaths and I'm like, why haven't I fallen asleep? It's been 172 breaths. That's terrible. But I like counting up till 10 and then backwards back down to one. So it's like an in on one, out on two, in on three, out on four, all the way up to 10. And then you go backwards down to one and then back up to 10 and down to one so that you have no idea how many times you've done this. And when you're doing that, I like to visualize the breath going like in through your nose and down into your, so like it's like a full sensory experience. So that's one I really like because it has like a physiological component and it lets your brain focus on something that isn't, am I going to sleep tonight? Why won't I fall asleep yet? Is it right? Like you don't want to give your brain a calming activity. The other one I like is visualization. So you go to sleep, you turn the lights off, you close your eyes, and then you put yourself mentally into like your favorite, most relaxing place. Maybe it's like at a lake with mountains, and you really try to see it and you try to hear it and you fill in as much detail in your mind as possible. It's very relaxing, it's mildly engaging, and hopefully it'll let you drift down.
Taking notes here. I think you mentioned with the melatonin, I don't know if you touched, I can't remember if you touched on the vitamin aspect. I mean, that's a big thing too, as well, for melatonin, that people often turn to as well.
Yeah, I mean, I talk to your doctor about supplements,
Mhm.
and all I can say about that.
Okay. What about persons having menopause, like hot flashes, that also interrupts sleep as well?
Yeah, totally. It's menopause can really mess up sleep, right? Anything hormonal can really mess up sleep. Again, that's something you should talk to your gynecologist about.
Mhm. Did you mention treatment for REM sleep behavior disorder?
Um, no, I did not. Um, honestly, for REM sleep behavior disorder, a lot of it is like how to predict. It's okay to have it, right? It's about how to protect your bedmate and how to protect yourself. So, some some of the treatments are like wearing bells on your wrists so that if you start to act out your dreams, the bells wake you up. We recommend that people don't share a bed when they have it because you're just putting yourself at risk. They make bed alarms for people who like leave the bed or could fall out of the bed. You might want like a bed gate or a bed alarm so that if you leave the bed, it sounds the alarm and wakes you up. It's really just about safety planning. You can't treat it, you can just manage it from a safety perspective.
Okay. What are some ways to alleviate restless leg syndrome?
Um, that one, that's the L-DOPA. Yeah. So the dopamine agonist treatments can help with that.
Does sleep improve when co-sleeping with children?
I think that's probably individual preference. I mean, what a lot of the data says is that like anytime you invite a creature, whether it's your partner, a child, the dog, into your bed, usually you see a decrease in quality of sleep because every time they move, you wake up a little bit. And so the more creatures in your bed, the more you're increasing your chances of waking up. Now, if you have like anxiety about being away from your kid or like, with new parents, there's a lot of stuff going on there. So if it makes you feel calmer and more relaxed, sure, why not? But in general, it's kind of bonkers that we like assume that people share their bed with their partners and their animals and all these things. It's really not an ideal sleep environment, but here we do it.
Yes. What medications are more associated with insomnia?
So one of the only like FDA approved medications for insomnia is trazodone. So trazodone is the only one that's been indicated that you can take long term. A lot of people will use like things like zolpidem or Ambien for short term insomnia, or benzodiazepines like Ativan or Xanax for short term insomnia. Um, they're not approved for long term use. That's like the main thing. And with older adults, which is kind of where I really specialize, Ambien, benzos, all of those are going to make them have a very high risk for falling, um, because they impact balance and gait, and they make you really drowsy. And older adults get out of bed a lot at night, so they're not great. They're not great. But if you're going to take an Ambien while you're traveling overseas to help you get onto there are like good uses for them. So like I've been on steroids, and anytime I go on a steroid, I'm like, you have to write me a script for Ambien, otherwise I'm going to be awake for 7 days in a row and I'm going to lose my mind. So it just depends on like what the use is.
Is there a herbal that you recommend for sleep apnea?
Talk to your doctor.
Okay. And for patients who are gabapentin, I'm not sure.
Gabapentin, yeah.
Okay. I'll butcher that.
Gabapentin can be helpful for sleep. So gabapentin like kind of reduces nerve pain. And gabapentin can be a little drowsy for people.
Okay.
Oh, workforce. Okay. So shift schedule are tricky. Um, ugh, shift workers are really hard. Uh, it's that might be a good use case for melatonin or like occasional medications to talk to your doctor about. But the main thing here is you want to try to trick your brain into thinking it's daytime when it's nighttime and nighttime when it's daytime. So really try to control your environment. There's this idea, there's a word that I like to use, Zeitgebers, which is a German word for like light cues. Um, so when our eyes see sunlight, it actually triggers hormones to be produced to create wakefulness. So I would get a SAD lamp, seasonal affective disorder lamp, of at least 15,000 lumens. And so, when you wake up at night, put yourself in front of the SAD lamp for 15 minutes to help be like, it's daytime now. And then blackout curtains during the day. That's kind of the best we can do.
Okay. Do all cultures view sleep importance the same way?
That's a great question. I think probably, right? Like this is like it's a biological drive. I think that we've gotten really fixated on it. I think that like social media has really turned everyone into like an armchair sleep specialist, and it's not all information is not created equal. I think our culture fixates a lot on sleep, but I would assume that a lot, like, it might just be easier in other cultures, but I don't know. It's a good question. I'll have to think about that.
What are your thoughts on all the new contraptions slash inventions out there for helping babies sleep? For example, weighted blankets, sleeper noise machines, etc.
I don't like the weighted blanket. So I'm not a pediatric expert. My expertise is in geriatrics, but I am a mom of two and I am a compulsive researcher. Noise machines make a lot of sense scientifically. The noise machine, so I sleep with white noise. My kids sleep with white noise. White noise actually does something to our brain waves and helps us relax. And moreover, with like newborns, the white noise mimics the sound that they heard in utero. And so the white noise, totally evidence-based. Weighted blankets for a baby? Absolutely not. That sounds like a terrible idea, a really good way to like not like don't. I don't think that's safe unless it's been specifically cleared by your pediatrician because of the size of your child. Um, Weighted blankets for older kids, especially kids with like sensory processing issues, makes a lot of sense, but like babies and newborns, no thank you. Because they also can't tell you if they hate it, which feels like a problem.
Great. So I know we're at 11 o'clock, Dr. Kozlov, and I want to be respectful of your time and everyone else's. I know we have like about 3 more questions, and I could always send that to you to answer.
I can
Uh,
do a few. I can finish these 3 questions.
okay, all right.
Okay. Recommend a home sleep apnea test. No, doctor, because let's say you had it, right? Like let your doctor prescribe the sleep apnea test. If they prescribe you a home test, that's fine, but this really needs to be diagnosed by a sleep medicine expert. Magnesium can have like relaxing or sleep inducing effects, but again, talk to your doctor before you so here's my rule with supplements. Anything that might improve your life, right? Like if we're going to believe that the supplement could change something for you, it has just as high a chance of changing something negatively, right? So talk to your doctor and ask for that like I wouldn't be ingesting substances without a medical doctor telling me it's okay. If it's like naturally occurring in the foods we eat and drink, fine. But when we start adding supplements, I would just check in with your medical doctor. Magnesium can also be really tough on the stomach. So it is a supplement that doctors tend to be okay with people taking, but not like across the board. If you have like any GI problems, I think that that's probably not a good supplement for you. Um, does the CPAP machine affect your sinus passageways? No, CPAP is going to make snoring better. It opens you up. So snoring is like the restriction of it. CPAP will open you up. And then that looks like a question for you about credit.
So yeah, I'll address that in a few.
Okay. I think I hit them all.
All right. Well, thank you again, Dr. Kozlov. This was really great. I definitely noted a lot of these things in my head for my own benefits, but I really appreciate your time, your expertise, in answering all these great questions. To those who are looking for credits, I am going to put the QR code. Dr. Kozlov, you can log off because I'll be on here for a little while where I can
Bye
share
bye,
it.
everyone. Thank you.
Thank you again. I will also share we just put this up here for you that where you can scan the QR code for the evaluation. Please fill out the evaluation so you can receive your credits, your public health CHES or nursing credits. So I'll have this up for a while. I'll also again share it at the once I log off of the webinar. And I'll get those slides over to you all as well. Thank you again for joining the webinar, and I will be on here just for a little while so that way you can scan the QR code. If you're unable to scan the QR code, no worries. I will share this link after I log off of this webinar. Okay, I am going to log off now. If you weren't able to get the evaluation link, I will resend the link in an email. That way everyone can have access to the evaluation. Again, we'll be offering nursing CHES and public health credits. Thank you all again for joining the webinar, and take great care.